dueling perspectives.
Oftentimes they have these myths of like, oh, my child's only a quarter or half a diopter, just like you mentioned, Glenda.
I mean, the parents will talk and they will start asking their friends why their kids are in glasses and not in Ortho-K or not in MySight.
So that applies to the primary eye care practitioner. They just, don't really understand pre-myopia.
Welcome to another Dueling Perspective. I'm your host, Dr. Diana Shechtman. This podcast is brought to you by Fluorescene Media, company behind ODs on Facebook. Please subscribe to our YouTube channel. Today's duel is a hot topic, and I'm sure many of you guys have asked the question, what's the right control for myopia? I am delighted to introduce my friend, nationally recognized speaker in myopia management, Dr. Glenda Aleman. She truly has embraced this topic beyond belief, and she is the owner of OK Love. Also, Dr. Chandler Mann, the owner of Stone Oak and the founder of Mann's Myopia Institute. That's pretty impressive accomplishment there, Dr. Mann.
Thank you, Diana.
You are equally passionate about this topic at hand and have actually received awards in contact lens industries. Welcome to you both. I can't wait to hear you guys. Collaborative work, as an emphasis in our previous episode, is definitely key in myopia control. So I want to rely on our company partnerships and thank them as well. And for this particular podcast, I wanted to thank Euclid. They are definitely a leader in an entrusted company, both for Ortho-K and for scleral lenses. And interesting enough, they're rightfully named after the father of geometry, for, in my opinion, and I'm sure you both have agreed, that their mission is to reshape vision. Let's start with today's quote. Benjamin Franklin stated, "An ounce of prevention is worth a pound of cure." This will be incredibly relevant in myopia. Let us get started with you. Ladies first, Glenda. You're nationally recognized. You're amazing at this topic. I want to hear a little bit, if you could, why did you decide to embrace myopia management?
Well, first of all, thank you so much for having me here. And it is such an honor and a pleasure to be with you because you are one of my dearest professors in optometry school. So thank you. And Chandler, it's such a great pleasure to be doing this with you as well. So I started my journey in myopia management early when I was still in optometry school. I knew that I had a big passion for working with pediatrics. I didn't know that I wanted to do myopia management until I had a lecture with Dr. Ziegler. And once I learned about myopia management and Ortho-K, it was no more question. I knew that I had to do myopia management because it's so prevalent in the pediatric community. Luckily for me, my first job out of optometry school, I got very fortunate to start working in a practice that was doing myopia management and Ortho-K. So I started first, as a doctor, but I really got passionate once I started working with my patients and I saw the impact of having done Ortho-K on the patients and how it changed their lives. So once I started in my own practice, I was actually practicing in Walmart. And when I really became passionate about myopia management was when I had this one myopic patient. It was my first Ortho-K patient. And this mother was willing to go to a different practice to get her topographies for her son done, and come back to my office to do Ortho-K. So seeing her motivation and seeing that parents were willing to go, above and beyond for their kids, I realized the importance and the significance that Ortho-K had on my patients. And that's really when I became passionate about myopia management. And I really want to emphasize here that that's when I decided that I needed to learn about other treatment modalities, not just Ortho-K, because, doing just Ortho-K was limiting my reach to be able to treat more patients.
I love your stories, Glenda. Where you were, where you are today, and the pride and joy I see as you continue to grow is incredible. So, Chandler, tell me a little bit about your passion. What sparked it?
So I'm quite a bit greener in this field than Glenda, but she has taught me a lot actually in my initial career in myopia management, which is fun. Something that sparked my passion was actually I had a very close family member that had two bilateral retinal detachments from high myopia and elongated axial length. And it significantly, now he kept vision in both eyes, which was great, but that significantly impacted kind of what he, wanted to do. It obviously was very, very scary for him, and kind of scary for us as a family and friends as well. And so that was kind of in my initial days in optometry school. And so when I started, researching kind of what we can do and talking to different teachers, Dr. Ashley Tucker was one of my professors in optometry school, and I have a very close relationship with her now. She's an amazing friend and mentor. So that's kind of helped build my passion into myopia management. And then I went practicing at a ophthalmology group, a amazing experience in Houston at Berkeley Eye Center with some fantastic physicians. But myopia management wasn't really in our, I guess, our protocol, and it wasn't really in our practice style, as you know. It's just difficult to spend that much time in a practice style like that with a patient. So I was doing, some off-label atropine, a MiSight here or there, but we also didn't see a lot of kids. But I found that was my most enjoyable part of practicing, was that one or two, every couple months that I'd be able to see and help make a difference for there. So when I moved to San Antonio and opened Stone Oak Vision Source, which is my practice now, that was something that I wanted to be kind of a foundational piece in my practice. Now, I practice, full family practice, optometry, a lot of dry eye, but my main passion and majority of my focus is on myopia management.
And you brought something up where initially where you started, you didn't have a lot of myopic management. We know myopia, it's definitely, both of you guys, I'm sure you're aware, it's an epidemic. 1/3 of our children are myopic, and it's predicted to be a pandemic where 50% of the global population is going to be myopic in 2050. But you yourself stated it. You had a passion, yet you weren't doing as much. So, question kind of back to that perspective. I believe that the numbers are less than 20% of the eye care providers really provide myopia management or even refer out if they don't know or don't feel comfortable with doing it. Why do you think that is? We'll start with you first. Go ahead, Chandler, since you kind of went into that story where you weren't doing it as much. Is it the type of population? Do you think there's some challenges? Why do you think, if we know it's an epidemic, why a lot of people are not practicing it?
So I was doing as much as I could. So we just didn't have kind of we didn't have a pediatric patient base. Now I would still educate, even early on, I did a lot of post-refractive surgery and refractive consultations. So I would still educate the myopic parents, especially very, very high myopes, on the topic as well. So that was very, very helpful. But I think the big hiccup, or one of the big hiccups, is people are, one, I feel like they're nervous for some reason that they don't have the technology to be able to do it in office, which, as we know, we all talk about, we don't have to treat and manage myopia properly. Another thing is probably just the conversation with cost. People are, from what I've talked to, I've spent a lot of time with practitioners around my area, not just in Vision Source, but plenty of different fields of practice in my area, talking to them. And that seems to be the common theme, is that conversation with the parent and the cost conversation. But in my opinion, I mean, you don't really understand what someone values and where they'll put their finances. And 9 times out of 10, it's going to be towards their children's healthcare. So if we can kind of change that mindset and get everybody kind of have that mindset, I think that there's going to be a lot more adaptation and acceptance of making this the standard of care like it is.
Glenda, anything you want to add? You've been doing this for quite
Yeah.
some time.
Definitely. So, definitely one of the challenges that clinicians have is the lack of awareness. I literally just had lunch. I just posted a story on Instagram because I went to lunch with one of my colleagues, and her son is 3 years old, and she was like, "Oh yeah, my son is doing fine." And I asked her what was the prescription, and her son is at 3 years old. He's plus 0.5 in one eye and plus 0.75 in the other eye. And we know that a 6-year-old child should be at least a +1, if not more hyperopic. So giving that information, even though for this, my friend, she didn't know that her child is at risk of developing myopia. So I started to educate her, and I realized that a lot of our colleagues, I have all of my friends are optometrists, and they're amazing clinicians, but they really just don't know. And there's just, as much as we think we're talking about myopia management, there is not enough awareness. So that applies to the primary eye care practitioner. They just, don't really understand pre-myopia and the risk factors. The second thing is, for those that do want to practice myopia management, it's, they do have to invest in education, and that takes a lot of time to learn, all the different treatment modalities that are available. And one thing is that as optometrists, we are a very conservative profession. And what I'm finding out is that my colleagues, they want to know as much as possible. They want to understand the research, and until they feel very confident and comfortable with how much information they know about myopia, they don't get started. So I would say, like Chandler, even like nowadays, nobody knows. Nobody has all the answers. We're still just trying to figure it out. So I would say, don't let that, there is a lot of analysis paralysis where they want to know everything before they get started. And I feel that stops a lot of physicians from getting started with myopia management. And the other one is the financial burden that, you do have to invest, at least if you want to do Ortho-K, you want to make sure that you have a great topographer to get started with Ortho-K. So I think those are the three main issues: education, lack of awareness about myopia management and when to refer, and the initial investment that it takes.
Those are incredible points. And I think you also mentioned, so you were talking about, let's pretend I do want to get started tomorrow. Not me, God forbid, but that's because of I haven't worked on refractions for quite some time, so I can, but I do refer my patients now. I'm at the other end. I work in the ophthalmology practice, so I see the 10 diopter myops of a young patient who might be 25, 26, as a young child, and she's had an RD. She had a choroidal neovascular membrane. She's getting injections, and it becomes, do you have children? Have they been checked? Is anyone considering anything? Because oftentimes they have these myths of like, oh, my child's only a quarter or half a diopter, just like you
Yes.
mentioned, Glenda. And they've gone up one diopter or two. And here's the one where they back themselves up. It's the fault of the glasses. They've been wearing the glasses, and they begin very adapted to it. Or they're 15. Let me just wait. They'll get LASIK and cure all the problems. And I think those myths are major issues, I think, that we have to get into. So I deal with the other end, the complications. And those parents are, I think, are a little bit more bought into the fact because they've dealt with it. But let's pretend I wanted to start tomorrow. Again, not going to, but let's pretend I won't going to. Chandler, give me just your little quick portfolio in 2 minutes or less of what's out there, FDA approved or not. Just give it to me in a simple matter.
What I use personally.
Well, you can tell me what you use. Let's say you're trying to educate people, just like Glenda said. She'll talk about what she uses, but there's a portfolio, and sometimes she changes things around depending on the patient, personalized care. So what's out there? I want to learn what's out there, FDA approved or not, that can be used.
So I think that the easiest introduction to myopia control is MySight. So daily disposable soft contact lenses. They're extremely effective. They are FDA approved. Anecdotally, I found them to be even more effective than clinical studies. But again, that's only 3 years into practicing at my current practice. But very, very easy. It's insertion removal teach, just like a standard soft contact lens. Parents seem to grasp the idea of a soft contact lens, at least initially, a little bit better than Ortho-K. I do a lot of Ortho-K as well. I love Ortho-K, especially for athletes and kids with certain lifestyles. I think those are probably my two go-tos. I do use atropine off-label drop therapy as well, especially for kind of the early myopes like Glenda was talking about and the young ones. It's pretty effective as long as you kind of educate on the other methods as well. And if they're very, very young and you don't want to put them in contacts yet, atropine's a great kind of starter, and eventually, still have that conversation that we're going to get into one of the contact lens methods. I'm also in San Antonio, and I don't have super customizable Ortho-K skills yet like Glenda does. And we have a lot of astigmatism with Hispanic patients, as those who practice in areas with a lot of, Glenda will know, a lot of astigmatism. So I do quite a bit of off-label multifocal toric soft contacts as well, which are pretty effective and in combo with atropine drop therapy for kind of those faster progressors as well. It's been great.
So, Glenda, seasoned optometrist that you are, even though you look 20, you look amazing. What's you mentioned your go-to is usually Ortho-K. Tell me a little bit about the companies you use. Give me a little bit of the pros and cons regarding Ortho-K, because this is a great dueling perspective, because Chandler had mentioned that he uses a little bit of everything. He does kind of tend to go a little bit on the my side and talked about his perspective. I want to hear yours as well.
So I get this question a lot. I do about 95% Ortho-K. So majority of my patients are Ortho-K patients. The name of my office is OK Love because I love Ortho-K so much.
Well,
So
that's
I'm a,
okay, love. I didn't know. I thought it just meant okay, love you. Like I wasn't sure what it really meant.
no, it's
Actually,
the O from ortho and the K from keratology. So yeah,
years
orthokeratology.
as many years as we've known each other, this is the first time I realized what it all meant. Thank you for sharing that. Like now I really appreciate the love even more.
Okay,
Continue.
love. Yes. All right. So I that means I'm gonna go on and do an Instagram story about
You
the name of
should.
Okay Love. So anyway, so I love Ortho-K. It is very effective, and we do also have an Ortho-K lens that is approved for myopia management, and that's really important. Having big companies, coming into the playground of myopia management and getting these FDA approvals is critical because we do have parents that will not have their child enroll in a treatment unless it is FDA approved. So I think that's why it's really important to understand what treatments are FDA approved and what treatments are off label. So as Chandler mentioned, FDA approved is my site for myopia control, and for myopia management, we have AccuView Ability. Now, the companies that I use several companies because, just like when we're practicing with fitting soft lenses, there is not one size fits all. Majority of the lenses that are available commercially for Ortho-K only correct up to -5 or -6 diopters of myopia, and I have a lot more complex cases. So I use one of my favorite companies to use for my lower myopes up to -5 is Euclid. I like them because their system is very easy to use. They have great customer service, and their lenses, their first fit success rate is amazing. So if, I try to keep things simple, that one is my go-to for my lower minus, depending also on what location I'm at. I do also like to use AccuView Ability. That one also depends on the topographer that I have because they have a software guided fitting system. And when you have that, you have to make sure that you have a topographer that is compatible with the system. And for my higher myopes, because I do use a lot of custom Ortho-K, so for patients that have a lot of astigmatism, like Chandler mentioned, I use Wave, which is a fully customizable Ortho-K lens design. And again, depending on the location and depending on the topographer that I have, I will use Gov lenses, which is another great option for doctors that, like Chandler mentioned, if they're not to the point where they can do a fully custom design lens, they can order a Gov lens that has a lot more higher parameters.
And you mentioned topographer. Obviously, I'm sure incredibly important when you're fitting Ortho-K. Which topographers do you use usually?
So I have the Menmont. That was the first topographer that I got because, as we all know, when we are doing these custom design lenses or we're using a software guided fitting system, you have to have a topographer that is compatible with these softwares. And Medmont in the Ortho-K world, it is the gold standard for Ortho-K lenses because it is the most compatible with most of the softwares out there for designing Ortho-K lenses. I do also have, Maya, which is another topographer for a different company. But my my main topographer that I use for designing Ortho-K lenses is the Medmont.
What about you, Chandler? So besides, I assume you have a topographer in your office, correct?
I do, yes, ma'am.
Okay.
So
I
when I
want you to
first
tell me
start,
which
oh,
one,
sure.
and also tell me anything else, other instruments you may need, you think are incredibly valuable, at least for you in your particular practice.
Well, I have the Maya, as Glenda was saying, which is a great topographer from a cost basis standpoint, especially for cold start practices, because it does have the topography. I do a lot of dry eye too, and it's got my biography on there as well now, and it has a biometer, so we're able to kind of measure axial length and chart out the axial length as well, which is very, very helpful. Kind of like we said earlier, you don't have to have the axial length measurement to get started in myopia management, but it does prove very, very beneficial. Not only to be able to show the parents, but for your data tracking and ensuring that your treatment protocol and how you're working with the patient is actually as effective as you want it to be, and that you don't need to change course on anything. Now, like Glenda was saying, again, she does this, and I did not expect to be doing as much Ortho-K as I do now. So I do the Medmont, the new Pro looks pretty amazing to me. And like I was saying too, I didn't expect to be doing this much Ortho-K going forward, but I am chomping at the bit to hopefully get I'm starting to use Euclid, which will be fun because it seems more customizable. I do a lot of CRT. I do AccuViewability. Those are kind of my two main ones right now. I'm starting to use some Euclid because of the a little more customizability in the optic zone, which is nice. And then hopefully Wave one day. So we'll see. But from a topography basis, I mean, again, you don't have to have an A scan. You don't have to have a biometer to practice myopia management, especially if you're fitting my sight. I know this is dueling perspectives, and I do a lot of my sight, kind of my bread and butter. If you're fitting my sight, the good thing is, especially for a cold start like where I was, I mean, I only opened 27 months ago. For a cold start, my site is super easy. From a cost basis standpoint, you don't have to bring in that topographer right off the bat. Now, it does help a lot, one with capture rate and education of the parents to have that topography and biometer. But if you're wanting to just start in myopia management, and then hopefully get to kind of where I'm at, and then eventually we all can hopefully get to where Glenda's at. Bringing in technology like a good topographer is going to be very, very beneficial in the long run, but it's not totally necessary right off the bat, just because we have a soft lens option that's FDA approved to kind of help treat that stuff.
That's Glenda, you mentioned something interesting before. You talked about your lunch date, which I wasn't invited to, but we'll discuss that later.
Me either, Glenda.
You mentioned the fact that you went out with a friend. Your friend had this child. They were a plus 50 or so, plus one, and they should be plus 50.
0.5.
So they're literally going into myopia. So I want you to tell me a little bit about your management range. When do you really get started? Because some people are like, I think in our worlds, we always wait for the worst. It's like if there's a 10 diopter myope and the child is 5, you're thinking that's got to be your myopic management because they're 10. But it's like being proactive. Why are we waiting? And how much can we do when they're 10 diopters already? So let me know when to really get started, and diopter and age range. I think that's an important perspective for people to understand.
Absolutely. So whenever I lecture, I make it a point to really emphasize what pre-myopia is. So pre-myopia, we need to, I guess the reference should be a 6-year-old child should have at least one diopter of hyperopia or more plus. If they are more minus than one diopter, then that patient will most likely develop myopia. So that's when we need to be doing the education. There's so much research that has shown that before the onset of myopia, increasing outdoor activity can actually delay the onset of myopia. We can start low dose atropine treatment preventative. We still don't have a lot of research showing, to back that up, but we do know in clinical practice, I have done it with so many patients, and I have, successfully been able to delay the onset of myopia on those low plus patients. So I always like to tell, my friends, 6 years old, think of a +1 refractive error. Anything more minus than that, just think of this child will become pre-myopic. And that is the best time to start having these conversations, to start the education, and to start, monitoring these patients. So ideally, we will be monitoring them minimum, talking to the parents. And I always like to, because we don't have the research to back it up, I do like to give the patients, the parents, the option. We can monitor but we can start treatment. And most of the time, the parents want to go ahead and start a low dose atropine prophylactically. Don't wait until the child is -6, which is, to your point, that's what happens. I have so many of my friends saying, oh yeah, I'm watching this kid, he's doing fine, he progressed, half diopter last year, but he's still -4. I'm like, no, send them, start doing it now. When they are a low minus, they're a -2, -3, we have all the options. We can fit them on a MiSight lens, we can put them on low dose atropine. But when they become -8, -9, -10, which is when I'm getting these patients, the risk of maculopathy, the risk of complications is already there. And at that point, all I'm doing is really mitigating the myopia. I'm really trying to hold that patient where they are so they don't get any worse. But the damage is already done. So by the time they're -6, it's kind of too late. I mean, it's never too late to start helping them. But as far as reducing the risk of complications, they already have a significant risk of developing maculopathy, retinal detachment, glaucoma, all the complications that we know are associated with myopia. So thank you, because that is such a great.
It makes you pretty sick when you get those cases.
I know, 'cause nothing depending on you.
I've started getting those sent to me now. And like Glenda was saying, because Glenda has a very good, relationship with a lot of practitioners around her, to help build OK Love as well. So something else I would kind of just piggyback off that and talk to practitioners who are wanting to get started or are very, very passionate about this. Go around to other practitioners in the area, because the last thing you want to see is you have a parent bring a kid in just because maybe they moved a couple neighborhoods over, or they couldn't get in at the other office, and they come to you, and the story, like Glenda's saying, they're -6, -7, -8, and they're young, and they're like, oh yeah, we've been changing glasses every 3, 4, 6 months. And you don't want your colleagues and your friends and your neighbors to uh, practice in that style, because that's not kind of the standard that we hold ourselves to nowadays. So pop out there to your neighbors and just talk to them about kind of the education, and tell them, hey, if you don't want to take these cases on, please send them to me. And you'd be surprised at how many people do that, because they really do care. They just might not be in the practice modality to handle those, or they might not have the comfort level just yet. But then maybe you could, at least you can educate them on the topic. They can give that other parent some educational kind of material or discussion as well, to kind of help prep them for when they get to your office. So yeah, it kind of makes you sick when you get cases like that and they just pop in and it's that far gone when you could have already started. I have been to Glenda's lectures, and she does say what she just said, and I actually kind of subscribe to that method, with giving the parent and the kid, the option to start, low dose atropine off label. You educate them again that it's, not FDA approved, but the data is there, and educate them with the atropine and the outdoor activity and sunlight at an early age, because a lot of times, like she said, parents are going to want to prevent, and preventative medicine is the best medicine. So
100%.
yeah.
Back to my
And going back to your quote, yes, thank you. So Mark Bullimore and Noel Brennan, who are dear friends of mine, they wrote this paper, and it's referencing that quote. And it is that 1 year of prevention is equal to 3 years of treatments. So if we can delay the onset of myopia by 1 year, that's equal to that patient being in treatment for 3 years. So, that's another point that I love to always include in my lectures. And I didn't answer the question, Diana, about the age. So as we all know, it is recommended that every child has an eye exam before they turn 12 months, at 3 years, and before they start school. Those are the 3 points that we need to be telling all of our patients. Any adult patient that I have, I'm always asking them, like, do you have children? If they say no, like, well, you have nephews, you have friends that have kids, tell them they need to bring their kids to the optometrist, before they turn 1 year, at 3 years, and before they start school. Those are the three key points. And a lot of, for myopia, what I'm seeing, and I'm sure Chandler has seen this too, is that we're having younger and younger patients with onset of myopia at
It's crazy.
age 3 years old. I have my youngest Ortho-K patient is 4 years old, and he's -4. So just another, I want to give this point. If the child's age matches the diopters of myopia, or the diopters of myopia matches the child's age, that is a huge predictor that that child will have high myopia. So a 3-year-old having -3, that we need to start right away with that patient.
And all that is basically what we're doing now. Unfortunately, the reason for that is, and I think after COVID, you probably saw quite a bit of that, is being secluded in this world. Glenda, you and I are old enough, I'm a lot older, but old enough to know that we found out about our world when we were outside, curious, and we learned about it. Everyone now supplies themselves right here. There's people listening to us on their computer. There are kids with iPhones at age 4, 5. So the myopia is going to continue to be progressive. It happens, unfortunately. So I think it's going to get worse and worse for us. Going back to what you were mentioning, so you mentioned the diopters, you mentioned the age group. How about, okay, I started working on my patient with myopia, but now I want to kind of stop, like slow the process down. It's not a lifetime goal here. And I'm sure there's a lot of data out there regarding the age. I know children usually stabilize around ages 15 to 18. I am certain you guys have seen progressions and over the age of 20, especially now. So how do you make a judgment call into how long you do it, maybe expand upon it, and treat an extent like we would do in the back of the eye kind of thing? How do you work? Give me your clinical pearls. We'll start, Chandler, we'll start with you since Glenda just took off. And I'm sure Glenda will always add something extra on it. So I'll give you the seat right here.
So your question was basically, how do we know when to pull them out of treatment or
Yeah,
stop
like how
treatment,
long do you do it? Do you
are you
do it
saying,
based on
do you
age?
start somebody who's older? Is that what you're
Either
asking?
one. Give me
Either one. Okay. I mean, just anecdotally, I know the FDA approvals that we have for this stuff is for a certain age range, right? But I've had kids that have come. I mean, kids, they're college age, that have come to me, and they've been progressive for a decade, right? And it actually is starting to pick. It's funny because we progress, as we know, a lot faster at age 8 than we do at age 12, and a lot faster at age 12 than we do at 15, and so on. But sometimes you'll get these cases where these kids will actually pick up progression, especially in higher education, when they're doing a lot more indoor, a lot more screens, a lot more studying. And I've had really, really good success with, I can list off the top of my head at least 5 of them in the past 24 months that have been progressive and were progressive for a while, but it started to pick up a lot quicker, that I've started treatment on, and they've been extremely stable since we started treatment. A couple of them are in my site, a couple are in Ortho-K. They've both been very, very effective for them. And they've all been super happy, because when you start to get old enough to kind of grasp what can happen and how myopic you actually are, and then you have somebody educate you on it, when you're that age, you're going to go do some research yourself. So they get really, really excited. They're kind of like parents of the young kids that they get excited when you have success. Like, that age group gets really excited to kind of, hey, if there's something, and I mean, nowadays there's so much access to information with, I don't know, the Gen Z or the TikToks and the Instagram and all that stuff. But there's so much access to info that, there's a lot of stuff out there talking about, disease that's sequelae from myopia, from progressive myopia. And they find that, and they get excited when they can help prevent something. That generation, as locked in and tech savvy as they are very, very into their health, and they're very into prevention and making sure what they're doing is going to keep them alive and alive at a more comfortable level longer. So this just goes along with that. I'll let Glenda handle the first part of that question, though, because she's been doing this longer, so she's gonna have better kind of anecdotal evidence and kind of clinical experience with when to pull kids out and to put them back in, or so on and so forth.
Glenda, floor is yours.
Yes.
Sorry to
Thank
throw it to you,
you.
Glenda, but you're just gonna have better answer for the crowd than I am.
No, absolutely. So I do want to address that from, because like I mentioned, a lot of the clinicians want to practice medical-based optometry. So we do have some research showing some trends based on ethnicity. And I think that's really important because when parents come to us and we're talking about these long-term treatments, they want to kind of have in their head like an endpoint. So it's really good to reference back to those studies and know that, and I tell them, okay, so based on the studies, they will slow down some ethnicities, like, for white Caucasians, they tend to slow down at age 16. So at least we're probably not going to stop at 16, but it gives the parent that idea, it gives them peace of mind at the moment that at least there is like hope at the end, of the tunnel, or light at the end of the tunnel. So I like to
They
use,
ask all the time.
they ask.
Sorry,
So I say,
they ask all the time. So how
right,
long are you going to do this for? When does this
right.
stop? Because yeah,
So I like to use that as a reference, and then I let them know, we can consider stopping the treatment for a moment and monitoring at this age, because that's the studies that we have. That's the data that shows that for your child, they will slow down around age 16. We know that African Americans will slow down progression around age 14. It's not what we're seeing in clinic, but this is the research that we have. But at least it gives me kind of like a talking point with the parents. And I always tell them, but ultimately, independently of the ethnicity of the patient, we want to have 2 years of consecutive years of no change in refractive error and no axial elongation to stop treatment. But I like the ethnicity studies again because it gives the parents hope. It gives us, sort of like a check-in point. Let's see where we are at age 14, at age 16, at age 18. So for Chinese, they take the longest to stabilize. So around 18 is when they tend to stabilize. And I think that is when they are in treatment. So this age, this ethnicity values that we have is for a child who has been on a myopia management treatment. They're going to stabilize a lot sooner than a child who is not on myopia management treatment, and they're going to continue to progress all the way into adulthood. Diana, does that answer the question?
Oh, anything within this world answers beautifully the question. I probably learned more now than I learned in 4 years of optometry school.
I'm excited because I'm learning a ton right now
I
too.
know
This is great.
you guys are fantastic. I'm telling you, if this was part of my world, I would. It's just unfortunately, and even having a topographer wouldn't really be part of my retina world, but it would be part of my refractive world.
Can I ask Glenda a question real quick?
Yeah, please.
Just to kind of go off what you were saying. When you say the 2 years of refractive error stability, and you say 2 years of axial length stability, are you saying stability that's within normal physiological axial growth, or like age-related physiological change, or just
So in
stability like
axial
no
length,
change at all?
so for axial length, we know that after age 14, there should be no change at all
No
in their
change,
axial
right?
length,
Right.
right? So, or 0.01 is what we
Right.
expect. So you need to understand those axial length data and what to
Right.
expect. So after 14, change of 0.01 is what we expect. Anything more than that is considered elongation. So yes, Chandler, does that answer the question? So we do want to make
It
sure that it's
does.
within the physiological growth. We have to consider
Yeah.
that. And for that, maybe I'll elaborate a little bit more. As Chandler mentioned earlier, a younger child will progress more, but also their eye will, physiologically speaking, will grow faster. So when we're looking at axial lengths, 0.3 change on a 4-year-old is actually normal. It's expected due to their physiological growth. But if we look at the same 0.3 growth on a 12-year-old, that is actually not normal, because on a 12-year-old, it should be a lot less than that. And when we're looking at no change in axial length or stable axial elongation, is we want to take those information, those data, those points into consideration.
I love how Chandler's actually taking notes. Like he's literally like.
I am. I literally was right. I was writing a couple
getting a
notes.
recording of this because I'm using this. Chandler stating. This is great. So,
It's just it's great information, but it's great to be able to convey it. Like we can know that information, and I've
of course,
you know we have cool charts. Dr. Kwan posted one on LinkedIn the other day. A colleague of his sent to him. It's got really good talking about axial length growth for emetropic and myopic eyes for age ranges. So it's good. But to hear Glenda how the way she kind of presents that and thinks about it in clinically or in clinic, it's pretty awesome. Go ahead, Diane. Sorry.
well, both of you guys were
Yeah.
amazing, and we honestly, you gave me a lot to think about here. Let's wrap up with a clinical pearl. I want, we'll go with you, Chandler, since you were finishing up. Give me anything, a great story, something you want them to remember. It doesn't have to be a great story. Give me some of the burdens or myths or how to deal with parents. Just a great clinical pearl that you want someone to take home with.
I think one of the things that we've mentioned it before, but I think if you want to build a myopia management practice or you want to get more myopia management kids, myopic kids in your practice that you can treat and help, I mean, the best thing that you can do from what I found early on is have the conversation with the parents. We harp on this all the time. Any lecture you go to is probably going to talk about that too. But that really is a foundational tool to getting yourself off the. I mean, I started 27 months ago with 0 kids in treatment. I've got over 200 now. And a large portion of that is just from me talk. Do you have kids, right? You like to get to know your patients too. And nobody likes talking about anything more than parents like talking about their kids. And then if you can give them an avenue to potentially help their kid, I mean, 80% of the time you'll get, maybe not 80%, let's say 70% of the time you'll get these kids in and they'll be emetropic or hyperopic. And sometimes they'll bring in like their 21-year-old kid who's, a plus 150 and they're like, can you help him? But talking to the parents is going to be at first, that's like, there's your referral base right there. And then they're going to, if you can build a team that's passionate about this stuff and make this an experience for the kids and relay that passion to the parents and the kids themselves, they talk. I mean, the parents will talk and they will start asking their friends why their kids are in glasses and not in Ortho-K or not in MySight or not doing some sort of myopia control. Or if their kids are in glasses, sometimes you'll educate the parents enough. They're like, oh, is your kid doing atropine drops too? And the other parent has no idea. But you become amazed when how passionate the parents become about this and how passionate the kids do. And you will start to open the floodgates for myopia management candidates just because they're going to be so proud that they're doing something to help their kid and they want to help their friends' kids too. So that's going to be, to me, from a clinical pearl standpoint, from like a practice building standpoint,
Excellent.
use that time in your chair with your 35-year-old mom of 3. Give her great exam, but use that extra couple minutes to kind of educate her on this stuff too. And if her kids are, 1, 2, 3 years old, say, hey, we still recommend the exam, like Glenda said, and you can continue bringing them in and we'll just start measuring their axial length and start tracking their data. And if the time comes, we'll have the conversation about the options. So
Glenda, give me your story, clinical pearl. Doesn't have to be the parent, maybe staff related training or, revenue reward, patient burden, whatever you want as a clinical pearl you want someone to take with them.
Well, I think that Chandler did a great lead. So I would say do everything that he just said to get started. And let's assume you did what he said and you started having those conversations, planting those seeds. Now you have a few patients on, MySight, you have a few patients on atropine, and you're like, oh my God, you feel invigorated. I'm ready for Ortho-K. So once you're there and you're ready for Ortho-K, I'm going to tell you that the best thing you can do for yourself is to find those ideal patients to get started. So what is an ideal patient to get started with Ortho-K is going to be a low myop, -1 to -4, closest to sphere, so very little to no astigmatism, because you want to make sure that you're successful, that you want to feel confident about what you're doing. And once you get a few of those easy cases under your belt, and for those cases, Euclid is an amazing lens to get started. They're so easy to work with, and they're amazing. They have great support, especially if you're getting started. The other thing I want to say related to Ortho-K, because, of course, I'm the advocate for Ortho-K here, is once you set yourself for success with those easy cases, the next best thing that you can do is to set the right expectations with the parents. So in myopia management with Ortho-K, we say you want to under promise and over deliver, so that you don't set yourself up for, a uncomfortable conversation with the parent. And lastly, another point I want to say is investing in the education early in the process is going to save you a lot of time later on. So you want to make sure that you are telling patients and parents what to expect during the first couple of weeks of Ortho-K. That's going to save you so much time. Make sure you invest your time in giving them proper education on how to clean and maintain their lenses. That's going to save us complications down the line. And then lastly, make sure that you give them written down what solutions and eye drops to use, and that you're always checking them. So if you do what Chandler said and you add what I did, then you guys are all set to get started.
ChatGPT is a great friend to build like a contact lens dispensing education safety pamphlet you can give to patients, like Glenda was saying. I mean, obviously make sure you look at it and make sure it's up to standard, but if people use ChatGPT, we've used that all the time, and that's like a great way to throw together an awesome little sheet that you can give for the instructions, like Glenda was saying, and they use it, and it really helps.
And lastly, I don't want to, self-promote, but if you don't know where to get started, we are having an OK Love bootcamp that is we put all these resources and tie them up with a rope and give it to you all ready to get started with your myopia management practice. So we actually have all those educational materials, Chandler, that we give out at the OK Love bootcamp.
Look at
now
that.
I'm like all over.
There you go.
Okay, love. Like I have this whole entire spin on this. But the more you guys do this, the less patients I'll be seeing, which is fantastic. Because at our clinic, we see high myopes with choroidal neovascular membranes, the whole entire world of myopic tractional maculopathies, RDs, retinal breaks, etc. So I'll be seeing less patients because you guys are doing a fantastic job of what you do.
That's the
So
goal.
that ounce of prevention will make a big difference going all the way. I do want to thank you both. You guys were incredible. You gave me a lot to think about, honestly. And to be honest, I don't promote as much to the parents. And in forthcoming, I will. I think you're really giving me, I'm not going to be the one doing it, but it's going to give me the perspective of really kind of looking at my myopic patient a little more closely and talking to them about their children and sending them out to my wonderful colleagues, such as Glenda, because I have her right here around the corner, and so on. The landscape is certainly rapidly growing, and I think the vigilant work that you both have done it's incredible. Let us keep the conversations going. I'm hoping you guys could tune into other dueling perspectives at hand. I want to let the audience know not to forget to subscribe to Fluorescene Media. And I want to thank you both. I want to thank you, Clid. And I'm your host, Dr. Diana Shechtman, and that's a wrap.
You're awesome. Thanks, guys.
Thank you so
much. That was so fun.
Thank you to our guests for joining us today and sharing your insights. And thank you to our listeners for tuning in. See you next time.